I think we have to, oh, good, my talk is up, so I had to change over the computers. Yeah, I mean, this seems a little bit off topic compared to the first two talks, but I really wanted to put this concept out there because I think it's important in how we're, to generate some discussion, to think how we're interpreting the data that we're seeing with the direct-acting antivirals, and probably more importantly, the immunotherapies that are really maturing now. So we're seeing them come in to make sure that we're thinking beyond just T-cell response, surface antigen decline, to really try and understand what's happening. And so with a topic like immunological editing, you can really get into the weeds here. I'm going to try not to, and I'm going to try and keep it relatively short, but just to present this concept of, we'll see. There may be some evidence. I have some evidence, and whether it's happening or not, I think we really need to do some more work on this. But I will be talking about a couple of different compounds, so these are my disclosures. And there we go. So what is the concept of immune editing? So this really came largely from the cancer field. And so this is where the immune cells infiltrate the tumor, and then they start killing tumor cells in an antigen-specific or NK cell-dependent way, and eventually you can reduce the tumor. You kill most of the tumor cells, but because of the genetic instability of the tumors, they might lose the antigen, or they might lose their MHC class I, and so now they escape the immune system, and you have this sort of edited population that's invisible to the immune system, and so you can no longer control it, you get tumors, and this progresses. So what am I talking about immune editing in chronic hepatitis B? And I'm going to focus on infected versus integrated hepatocytes. So I want to think, and I'm going to focus on core and polymerase-specific T-cell immunity because these are the cells that we detect the most often in chronic hepatitis B in the periphery in the patients. And so the concept that I want to provide evidence for is that you have a T-cell response that's in the liver. These core and polymerase-specific T-cells are specifically recognizing infected cells. And so what happens is the infected cells get killed, and then they become replaced. And now you really enrich for integrated cells as you become e-antigen negative. So now thinking about this across the stages of hepatitis B, I'm really going to focus on this early stage, which is the clicker, there we go. Oh man, it's a bit delayed. I apologize for that. I'm really going to focus on the two extremes here. So the sort of e-antigen positive stages, I will go back and forth between E positive and immune tolerant, just out of necessity of the old papers. And then the inactive carrier state, the e-antigen negative state. And so now virologically, we have a pretty good understanding that in the E positive stage of infection that, this is data from Johns Hopkins looking at individual hepatocytes showing that there's a lot of cccDNA transcription and and viral proteins produced from the cccDNA during the HBe antigen positive stage. But as disease progresses, you end up with this sort of situation in the e-antigen negative patients where the liver seems to be dominated by hepatocytes that only integrated DNA producing hepatitis B surface antigen. So what do we know about the T-cell response between these sort of two extremes of the hepatitis B spectrum? Well, this data goes back almost 20 years, over 20 years actually, and so using tetramers to 3 different epitopes here, looking at the peripheral blood CD8 T-cell response, what they found is that patients with low viral replication had more HBV-specific T-cells in their peripheral blood, whereas patients with high viral replication seem to have almost no detectable tetramer-positive cells within their peripheral blood. And so more recently, the studies have been done looking at the levels of core-related antigen. And this is a functional experiment here, not tetramers, using intracellular cytokine staining. And what you can see is that these patients with high HBV core-related antigen, I'm sorry, this pointer keeps disconnecting on me. It's not advancing. The patients with the high core-related antigen levels have the lowest core-specific T cells in their peripheral blood. So these are also core-related antigen. They're going to be the e-antigen positive patients. And then we did a different functional assay using the IL-2 fluorospot assay. It is not, there we go. Using the IL-2 fluorospot assay, what we saw was a very similar trend. And here you're going from a setting of high viral replication, immune-tolerant patients, all the way to functional cure. And you can see the patients with the highest viral load, e antigen positive, in the periphery have the lowest T-cell responses. And this seems to increase as you get better viral control. This is my fault for switching between Mac and PC. So yes, this really kind of poses the question then, how can we have this concept of immune editing within the liver if we see the T-cell response is weakest in the patients where the viral replication is the highest? And so coming back to this, if you take a closer look at this, and this is sort of our data, but it's combining some of the other studies as well, the T-cells that are specifically reduced in the periphery are those recognizing the infected hepatocytes, the core-specific T-cells and the polymerase-specific T-cells. And so when you look in these e-antigen-positive patients and you try and just look at the proportion of T-cells specific for each of these antigens, what you see in the E-positive patients is it's dominated in the peripheral blood by polymerase and envelope. But as you proceed to e-antigen-negative infection, you end up getting this situation where the core-specific T-cells seen in orange become apparent in the peripheral blood. And so this is completely counterintuitive when you think immunologically. These patients are often older, and the longer you have a persistent infection, you should get more exhaustion and T-cell deletion, but this seems to be the opposite. So this doesn't sit particularly well for an immunologist. And so we started thinking about this and really come up with this I was thinking about this question, is the inverse correlation of peripheral T-cells with high viral replication, is this really due to exhaustion or deletion? I think this has been the prevailing notion with this idea of immune tolerant in the e-antigen positive patients. But we have to think about this. I mean, could these HBV specific T-cells in the e-antigen positive patients actually be in the liver rather than in the blood? And we know from a number of studies, again, going back over 20 years, that HBV-specific T-cells can be enriched 100-fold or even more within the liver compared to the blood in matched patients. And we've seen this across multiple studies using tetramers, using functional experiments. And so we know that HBV-specific T-cells are enriched within the liver. So if they are enriched, how do they get into the liver? And this is something I think is very important to the concept of immune editing that we want to talk about. And so this is data that I was kindly provided by Matteo Annacone, and this is using a transgenic mouse that expresses the core antigen within the hepatocytes. And the core-specific T-cells are in red, and the envelope-specific T-cells are in green. And you can see that the red cells are not moving, whereas the green cells zoom through the sinusoids and leave almost immediately. And so the way that this happens is when antigen-specific T-cells come into the liver, they crawl along the endothelium, and then when they recognize antigen presented by hepatocytes, they stop. And so they become trapped within the liver. So now, if HBV-specific T-cell enrichment is antigen-specific, how do we actually interpret our liver versus peripheral T-cell distribution across the stages of hepatitis B? And so coming back to the different stages and really thinking about the e-antigen positive stage and the fact that we saw fewer core-specific T-cells and polymerase-specific T-cells, you can come to this sort of hypothesis that in the e-antigen positive patients, the core and polymerase, particularly the core-specific T-cells, are coming out of the peripheral blood. So they're not detectable in the peripheral blood because there's so much core antigen and e-antigen within the hepatocytes. However, once they start to eliminate the infected cells, they start to transit back to the blood, and you get this stage of the e-antigen negative infection where now you have lots of cells in the periphery and still cells within the liver, which we know they'll stay because they have a tissue-resident phenotype, but many of these might transit back out. This is a hypothesis. This is not hard and fast data, but I want to put this into context of the direct-acting antivirals, because we know that immunology hasn't been studied in the direct-acting antivirals forever, and so we want to think about this. So think about CAMs in the first place. And so CAMs, we know they block core antigen assembly and encoding. So now you're left with this situation where you have this is really throwing off the whole flow. But you have this situation where you have a lot of core antigen now built up within the hepatocytes. And so when you get cytoplasmic antigen, this goes through the proteasome and it delivers peptides into the ER that are then loaded onto MHC class I molecules. And this MHC class I then presents to the CD8 T cells. And so, we don't have really any good data that I'm particularly aware of to suggest this is happening, but if this does happen, this could increase MHC class I antigen presentation on infected hepatocytes and actually make them better targets for core antigen-specific T cells. And so I want to hold up the Aligos, their new data with the CAM, showing that you actually get surface antigen decline in e-antigen positive patients. So we don't have any data on this, but with this concept of immune editing, you can think that it is possible that core-specific T cells within the liver might be eliminating the infected hepatocytes here. And the interesting thing about this is that this surface antigen decline was only seen in the E-positive patients. When they did the experiments in the E-negative patients, they didn't see a surface antigen decline because these cells are probably expressing surface antigen from the integrated cells and not the infected cells. Again, a hypothesis. And then further, Ed was talking extensively about the RNA interference strategies. And so now you can think of a therapy that suppresses all antigen production within the hepatocytes. And so now you have a situation where the antigen that was available there for proteasome degradation is actually turned off. And so no longer do you actually get the peptides produced, and so you don't get the antigen presented on the hepatocytes. And we showed in an in vitro study where we use infected HepG2 NTCP cells with HBV-specific CD8 T cells, that if you add siRNA to these infected hepatocytes and you knock down surface antigen production, you can reduce T cell recognition almost 80% in this in vitro co-culture. So what could happen here when we think about the RNA interference strategies, if you're reducing antigen within the liver, this could actually lead to recirculation of HBV-specific T cells to the periphery. Now, despite about 10 years worth of work on RNAi, we still don't have that T cell data. Ed highlighted a little bit of one or two studies, but we have no real concept of whether or not these T cells are actually going up to any great degree within the periphery. And when you think about this redistribution to the periphery, then you start thinking about what impact does therapeutic vaccination have if you have more T cells available for that therapeutic vaccine. So I will finish here on the last slide. I don't have any conclusions for anybody. Exactly. I got it. So, but I'm only presenting questions here, right? So, this question, does the level of viral replication impact the distribution of HBV-specific T cells? And so what we know is that most of the work with tetramers and everything has been done in the inactive E-negative carriers, because this is where the T cells are detectable within the peripheral blood. And then, are these peripheral T cells in E-negative patients the right one to actually gauge control? If they've left the liver, they've done their job. They may not be the ones we actually want to look at to understand what is eliminating the infected hepatocytes. And so, I put this in red just to highlight it again, but we know that the immune response hasn't been really studied particularly well in the DAA therapies. And I presented just a couple of examples, but you can start to apply this to different strategies and different things that we can talk about this in the discussion. The CAMs, they could enhance antigen presentation in infected hepatocytes. And does that make them a better target? And is that the reason for the surface antigen decline? And then this concept of the RNA. Could the RNAi therapies be the reason for such? We're seeing in some of these combination studies pretty large T cell responses after siRNA and therapeutic vaccination in these combination studies. And so does that recirculation to the periphery actually facilitate vaccine boosting? And then following these patients as the siRNA or the ASOs wash out to see if that decline in T cells or which T cells go into the liver and whether or not this is actually related to viral control will be interesting. But the last point that I'm going to point out is that no matter what, we need a better strategy, because to look at the intrahepatic T cells and determine if they really reflect the peripheral T cells at these different stages of infections. Tetramers aren't getting it done. Functional experiments don't give us enough. And so We just really need a better understanding, given what we think about the important role of T cells that are going to be responsible for ultimate control and functional cure in chronic hepatitis B patients. So I'll stop there. I think I got us a little bit ahead of schedule on this one, but I'm looking forward to the discussion, and hopefully it'll be a little bit smoother than my presentation. Thank you.
Thanks, Adam.